Good evening, everyone. My name is Sandra Katongo. I'm actually going to be taking you in this course, Integrated Reproductive Health. As you may be aware, this is a full course that tells us to say we're supposed to learn it for a period of 2 years, which is, I think, 4 semesters. Now, without going any further, before I think I even start what I'm supposed to talk about, please, this is a course that actually is going to equip us with the knowledge and the skills that we need to maintain reproductive health. Apart from that, when you look at this course itself, you will find that it is going to give us the skills that are needed, not for us just to pass exams, but also the skills that are going to help us deliver this woman, take care of this child, as well as preventing maternal fetal complications, and also helping this family actually plan on how many children and many other things that they would want to achieve as a couple. Now, when you look at it, I will go straight to the unit. So this course is actually made of Unit 1, which is an introduction to integrated reproductive health. Under here, we mostly look at the components of IRH. Apart from that, we also have the principles of IRH. These integrated reproductive health policies are just some of the things that we are supposed to know for knowledge's sake. But for the components of IRH as well as the principles of IRH, we are always supposed to know them. Now, apart from that, once Unit 1 is done, which is an introduction to integrated reproductive health, we have Unit 2. So this course that we are talking about, it is divided into 2 major components. The first one is what is called obstetrics and obstetric nursing. The second one is called gynecological and gynecology nursing. Now, this gynecology that we are talking about, it is sometimes referred to as obs and gyn. A combination of these 2 units is called obs and gyn by doctors and CEOs. But the reason why for us we call it integrated reproductive health is because we do not just look at obstetrics and gynecology. We look beyond that, because at some point we will have to advocate for this woman to say, no, maybe the number of children that you have, they are too many. You need to stop giving birth now. So Unit 2, obstetrics and obstetric nursing, this is just actually a component of IRH where we are going to be talking about pregnancy and pregnancy-related conditions. So under here, we'll learn some of the definitions, components of safe motherhood, how it is documented, and the documentations that are done. Apart from that, the reporting format, how does information move from the facilities to the district, even going to provincial as well as national level. But we know to say we can never understand this course, which involves a man and a woman, minus understanding how these individuals are made. Therefore, the first thing that we shall look at is applied anatomy and physiology of the male and female reproductive system. From there, after understanding how this man works, how this woman works, we shall actually move further and look at the menstrual cycle, because the woman has an additional physiology of interest to us as people who are doing obstetrics and gynecology itself. Apart from that, we shall also look at the female breast. We know to say at some point, for this man and for this woman to meet and start having children, there should be sexual excitement. So we shall look at the breast as a form of a structure that is responsible for sexual excitation, at the same time as a structure that helps us taking care of this baby that these two might plan to have in terms of lactation or breastfeeding. Apart from that, once we understand now the anatomy and physiology of both the man and the woman completely, we shall now imagine that this couple meets and they have actually copulated, of which fertilization now has taken place. So we shall look at fertilization and fetal development. how will this fetus be growing? Apart from that, we know to say, okay, since this woman is pregnant now, there are a lot of changes that will take place in her body. That includes the cardiovascular system, respiratory system, musculoskeletal system, the central nervous system, endocrine system, to mention but a few. Almost every system, including the renal system, they are going to be affected. Why? Because they need to adjust so that they actually manage to take care of this woman as well as taking care of the baby. So we shall look at the physiology of pregnancy, sometimes referred to as physiological changes of pregnancy. Once we understand that, we know to say, some women who come to say, no, I think I'm not able to eat the foods that I used to enjoy. No, I think I'm experiencing backache. No, every morning when I wake up, I experience vomiting. So we shall understand what are called minor disorders associated with this pregnancy that this woman is going to present with. Now, after we manage these minor disorders, we understand the physiology that is going on. It will be now time for us to take care of this woman. And there, the care that we shall give is under what we call antenatal care. We shall be reviewing this woman for antenatal every time she visits. And at the end of this topic, we shall understand then the difference between focused antenatal care as well as just the antenatal care that we know. Why? Because we know and we put into consideration, what if this woman comes, she's already a diabetic patient. They are suffering from diabetes mellitus. Apart from that, what if they have malaria during this pregnancy? Apart from that, what if they have another condition, for example, sickle cell disease? How are we going to take care of them? All right, how are we going to take care of them? Why are we talking about these antenatal cares and conditions? It's because we understand to say the care that a woman with an existing medical condition will need is different from what a normal woman will need. So that is why it's called the focused antenatal care. As I give care to this woman, I'll put into consideration, number one, her stage of life. Number two, the medical conditions attached to her. Therefore, if I tell women to say, no, you need to be coming every month end for antenatal care, some of them I might say, no, you should be coming here every 2 weeks. Why? Because I'm focusing on the woman's medical and physiological conditions. That's why the other one is called focused antenatal care. The other one is just called antenatal care. Now, from there, as we care for this woman, we'll assume also, okay, what if this woman now comes, she's HIV positive and she has come for antenatal, she's pregnant. All right. So what type of management are we going to give? All right. We don't want this child to have HIV and AIDS. So we shall put this woman on what we call PPTCT, prevention of parent to child transmission. That is where I'll look at the option B+. Some of you have heard about it before, especially the in-service, those of you that are already practicing nurses. Apart from that, okay, fine. Since we've managed all the conditions, it's now time for this woman to go into labor. This is where we shall look at the admission procedure. When they tell me to say, describe the admission procedure, how should I write it? When they tell me to say manage the first stage of labor, because we will understand to say labor has 3 main stages, which is first stage, second stage, as well as third stage. And these are normal physiological processes. Ladies and gentlemen, we shall understand to say, okay, when someone is in labor, we are never supposed to do maneuvers. Labor is a natural process that God designed in his own style, or I don't know, means. All right. So we are there as facilitators, just as inchmen, to check how this normal process is going on. Otherwise, we are never supposed to touch the baby. We move the baby around here and there. No, that's the reason why we're experiencing a lot of dystocia. We're experiencing a lot of PPH and many others. Why? Because we want to be technicians when someone is giving birth. So this insight will give us actually how we are supposed to handle ourselves in the delivery process. Apart from that, okay, we've delivered this woman, fine. Let's now look at the immediate care of the newborn. Apart from that, this immediate care of the newborn, since I'm the one who is taking you in pediatrics, we shall look at all these problems of the newborn and care of the newborn in the skills lab, as well as just physical. Okay, we shall look at asphyxia, RDS, or other respiratory distress syndrome. Some books will hear them mentioning to say this is hyaline membrane disease. So we shall look at these conditions, not in IRH, but we shall look at them in pediatrics. Apart from that, we'll look at postpartum, where we shall now know to say, okay, this woman now, all those changes that took place the time that she got pregnant, they need to go back to non-pregnant state. We no longer need the excess carbon dioxide. We no longer need the excess water. We no longer need the excess oxygen. So all these, the systems in the body, they will have to go back to non-pregnant state, as well as the uterus and also the reproductive system. We know to say, okay, they were malformed at some point, and therefore we need them to undergo the process called involution. To involute is to revert back, going back to the way you were. Apart from that, we'll also look at postnatal care, how we care for this woman when they come during the puerperium period, which is up to 6 weeks from the period of delivery or the time of delivery, up to 6 weeks. They will be coming, these women, for review, and we shall continue periodically monitoring them so that we are aware. Are they involuting well, or are the systems going back to the non-pregnant state on time? Are there any infections that this woman has developed from the time that she came for the labor wards? Apart from that, we'll also look at some of the medical disorders in pregnancy. That includes malaria, diabetes mellitus, heart diseases, hypertensive disorders in pregnancy, and hypertensive disorders in pregnancy. That is where we'll look at the eclampsia and pre-eclampsia. We'll also look at renal diseases. That includes the glomerulonephritis, nephrotic syndrome, nephritis, and many others. Then we understand to say, okay, these conditions that have been chosen here, they are conditions that interfere with normal physiological processes in one way or the other. Therefore, we are also worried to say, no, I think tuberculosis should be one of them. So we shall go further to look at pulmonary tuberculosis. Then we will not talk much about EMONC because nowadays we are no longer using EMONC. Almost all the hospitals, they have been equipped with emergency obstetric and neonatal care. So it's more like general now. Apart from that, we'll look at the obstetric complications. After the obstetric complications, that includes the antepartum hemorrhage, postpartum hemorrhage, anemia in pregnancy. We'll look at the woman, management of a woman undergoing induction of labor. What if this labor doesn't start on its own? Someone goes up to 42 weeks, you start wondering, are they pregnant for an elephant? They are not delivering yet. So what are we supposed to do? Fine. We know to say to prevent placenta insufficiency, where the placenta is aged and it cannot manage to sustain pregnancy by supplying the nutrients that are needed. You'll find that we are going to actually induce labor. And this is where we are going to learn the use of cytotech, which is used for termination of pregnancy. The other name for cytotech is misoprostol. How are we going to actually induce labor? Remember, we are using this for induction, not abortion yet. Okay. Apart from that, we shall also look at cesarean section. Instrumental delivery, you study on your own because nowadays we are no longer encouraging the use of instruments during labor and delivery. So we are not going to look at it now. Apart from that, sometimes you'll find that, okay, fine, this woman we've induced, but she's not responding to the drugs that we've given. The cytotech, they're not responding. What are we going to do? Or maybe she has cephalopelvic disproportion. Either the pelvis is contracted or the fetal head is too big. You know, there are babies that are born with very big heads. Just by looking at the baby who is 2 days old, you're able to tell what type of problems this woman has brought in the world. So we shall look at, okay, fine. Since we failed to deliver vaginally, let's now go for a cesarean section. So cesarean section, we shall look at it. How do we prepare this woman before they go to theater? Apart from that, how do we prepare them when they're in theater? How do we handle ourselves? How do we cut? What type of incisions are we going to make on this woman's abdomen so that we know to say we have lesser complications on both the mother as well as the fetus? Apart from that, these drugs used in obstetrics are supposed to be covered in pharmacology. But I understand where our background, so we shall still actually do these drugs. Which drugs are we using in obstetrics? Okay, related to labor and pregnancy. Why are we talking about drugs used? We understand to say this woman, the threshold, the synthesis rate of drugs and the absorption rates of these drugs when she is pregnant are very high. Since she reserved some water at the time she got pregnant, it means most of the drugs, even if we give in normal doses, they are not likely to respond because this woman is having a lot of water in her body that are diluting the same drug that we are giving. So we are supposed to understand, how do I adjust the drugs when I'm dealing with a pregnant woman? In case they come with malaria, what type of medications am I supposed to give and what is the reason why? At how many days of pregnancy can I give this type of a drug? This is what we understand when we talk about these drugs. And this will mark the end of pregnancy and pregnancy-related complications. Then we shall go to the other unit, which is gynecology and gynecological nursing. Gynecology and gynecological nursing, we are dealing with a woman who has come with a reproductive system condition, but they are not pregnant. That includes menarche, which is the onset of menses. What changes take place when someone starts their menses? Apart from that, what complications are we likely to find when this woman begins her menses? When do we expect higher chances of this woman developing hormonal imbalances? And when they come to the hospital as an adolescent, they have just commenced their menses. What are we supposed to advise them? Because menses, they are accompanied by depression and anxiety in this young girl that we are seeing. So we are supposed to manage that. Apart from that, we will go further looking at adolescent and sexuality, where we shall teach this adolescent how to conduct themselves when they are in sexual relationships. Apart from prevention of STIs, the nutritional supplements that they have, as well as peer education, them educating each other about sex and sexual life. Apart from that, we shall also look at menopause. Some women, when they are almost towards the ages of 45, 48, in between here, they start experiencing weird signs and symptoms. And these signs and symptoms, they are telling us to say, okay, this woman now, all the hormones that were relaxing her joints, that were relaxing her muscles, they have started going, they're diminishing. Therefore, she'll start having, no, my legs are paining, no, I'm always waking up tired, no, I always feel dizzy. Why? Because the hormones that were responsible for tissue maintenance, as well as muscle and joint relaxation, they are no longer being produced by this woman. So how do we help them and how do we manage them? Apart from that, these investigations that you are seeing here, we would have already done them. The procedures that you are seeing, they would have already been done in the skills lab. So for us, we will go straight to disorders of the menstrual system, where we'll find this woman. She has been having her menses for maybe 10, 11 days, even 2 weeks. They are not stopping. What are we going to do and what drugs are we going to use? Of course, it's not all the women that are going to respond to the drugs that we give, but there are always better options. Apart from that, some women will stay 3-5 months without seeing their menses. So us as clinicians, what type of drugs are we supposed to give them so that we relieve them of the pressure? You know, menses are more like a pride to this woman, but once they are not able to see them, they are not normal, it actually reduces their self-esteem. So it's our duty to bring and restore that back. Apart from that, we shall actually look at management of a woman, or preparation of a woman who is undergoing gynecological operations. That includes cervical cancer, what's its operations, as well as many others. When we are done with that, the drugs will combine drugs used in gynecology as well as drugs used in obstetrics. So we shall go further looking at abortions, post-abortal care, when someone aborts from homes, from wherever, how are we going to take care of them? Apart from that, once we are done with our abortions, we'll look at ectopic pregnancy as well as vulvovaginal infections, candidiasis, Bartholin's abscess, vaginitis, condyloma, syphilis, gonorrhea, and many others. And once we are done, we'll look at pelvic infections. And this is where we shall look at pelvic inflammatory disease, cervicitis, pelvic peritonitis, and many others. Then we shall go further trying to understand infertility problems, male infertility, female infertility, as well as the counseling that we can give to this couple. Remember, when a couple gets married, people will be expectant to say, okay, I think we are expecting children now. And immediately, time passes, 2 years, 3 years down the line, the first person will be suspected to say they have a problem. It's the woman. And in the actual sense, it is not always a woman who shall present with infertility problems. So it is us, the nurses, who are going out there to change the perception that society has. Okay? We shall actually look at male infertility and female infertility, both of them. And since we are talking about them, who understand to say we do not have to be quick to judge, because infertility is common in males as much as it is common in the females. Okay? Apart from that, some women experience gynecological problems like a fistula, which is an abnormal connections between 2 or more organs that normally do not communicate. A good example in our case is a vesical vaginal fistula, where this urinary bladder is now communicating with the vaginal canal. Urine will be dipping out 24/7 from this woman's birth canal. Apart from that, we can have also what we call a rectal vaginal fistula, where the rectum and the vaginal canal, they meet. And we'll find that this woman, after giving birth, is always having fecal matter in the canal. And you can imagine the level of distress that this woman has. I'm sure we've seen a lot of NGOs coming in to deal with that. That includes the Fistula Foundation. Apart from that, we'll look at the tumors, both non-cancerous, which are called benign tumors, as well as cancerous tumors, which are called malignant tumors. When we move, we shall actually look at cervical cancer screening services. How are we going to visually inspect these cervix with acetic acid? Apart from that, how are we going to get some samples from this woman's cervix? We can put on a stethoscope so that we are able to see, is she having the abnormal cells that are referred to as the cancerous cells or not? So that test is called the pap smear or Papa Nicholas smear. Then once we are done with gynecology on top there, we shall look at family planning. How do we conduct ourselves during family planning? How do we document? What types of family planning do we have, as well as how to inject and insert them? And last but not the least, we shall look at gender and health. This gender and health, this is where you will study on your own on GBV, advocacy. What are some of the duties of a nurse when it comes to advocacy? What are some of the gender roles that society has imposed on us? You know, a long time ago, most of the women actually were taught to say you are never supposed to say when your husband beats you, that is in a home. Apart from that, that wasn't considered to be right to most of us, because we know to say when someone has been beaten, they're supposed to wear out their anger. All right. So all those gender roles, relations, and cultural effects that we've had. Women a long time ago, they just used to sit at home. That's the reason why you can give them all the work, it's okay. But nowadays, where this is a career woman who is having actually work as much as you work as a man, then you expect her to do everything. You come back early, you start watching TV, and she's expected to pick the kids, watch them, do what. All those are some of the effects of culture that actually we shall look at under gender and health. Apart from that, these are some of the reasons why most of us are leading homes where one of us is not happy, because we know to say when someone is tired, they are not able to give their physical and psychological capabilities well. So this is what we shall look at. And by the time that will be done with this course, we know to say we shall be experts in both delivering this woman who has come in labor. She has come with complications, we shall deal with them. Apart from that, we shall also be good counselors dealing with couples who are unable to bear children, couples actually who are having coital problems, as well as many others. Apart from that, this is a very important course. When you look at the core competencies, you will find that you were expected to actually do deliveries of about 10, okay? You are supposed to conduct 5 deliveries, you observe 5, you do antenatal examinations, about 5 of them, postnatal examination, 5 of them, and you examine a newborn baby. When this baby is born, you start examining. So you are supposed to at least examine 5 babies. Then on the demonstration, you are supposed to actually do a lot of demonstration that includes the screening and examining clients, counseling for family planning, admission of clients, vaginal examination, breast examination, and many others, including manual vacuum aspiration. This woman comes, she has aborted, but most of the products of conception, they have been retained. We'll consider it an incomplete abortion. So the best procedure that we can do in this case is a manual vacuum aspiration. So we are supposed to do that in the skills lab, and God forbid if we will not have time to perform this type of a procedure, because they are the only life-saving procedures that we have in abortions. With that, actually, I'm sure all of us we've seen our what is our timetable. So I urge you all to be going through the PowerPoints that we are shared, so that at least by the time that you are coming to class, you have prior knowledge and you have areas where you can ask questions from. So the way we are going to conduct this lecture is an exam-based lecture. It's not more like a skill-based lecture, because we do not have time. A skill-based lecture, this is where we go topic by topic, but this time around, we shall be looking at the examinable topics, and they're the ones that we are going to focus on. So this is actually where the introductory session for this course ends. Please feel free to contact me. You have my numbers, and I wish you a lovely evening and a wonderful night.